Hello, good afternoon. So that's the region called scapular region. This is the topic for today. Welcome to one more session. Now, say today's session is a bit special. In fact, you'll be revising large amount of content of what we discussed in the previous sessions. That is the initial first 4 sessions. Right? So let's start. So when we talk about, say, scapular region, right? Actually, in simpler terms, we are dealing with shoulder region. So, scapula plus the humerus. Upper end. Right? So, they will be in sharp focus. So, let's see these structures. Now, what we'll do is those important points this time I have already written. So, it will become much more easier and we'll be saving some time in writing it so that we can discuss something extra. Right? So, that's how things would go. Okay. So, here is the first point. This is the greater tubercle, lateral most bony prominence. All you need to do is just touch over here and feel it by yourself. That's the point. You need to feel it. The moment you will touch it, you will get that yes, that's the lateral most bony prominence, and that is the greater tubercle. Right? That's the greater tubercle. This is the lateral most bony prominence. Now you know that this is covered by deltoid, right? That is what is giving that round contour of your shoulder. So there is something which is very interesting about this round contour. What's called as the cutaneous supply, right? Cutaneous supply. It is divided in the, let's say, like 2 parts, right? The upper half and the lower half. Right? So think it that way. The region which is like this, so upper half and the lower half. Now both these nerves, they will come into our discussion as we'll progress, right? So just at this point of time, this is like lateral supraclavicular nerve, right? So this lateral supraclavicular nerve and the lower one is the lateral cutaneous nerve, right? Obviously this is for arm, so it is for arm. Now when you look at the deltoid, right? Deltoid is like it has got the anterior fibers, it has got the medial fibers, it has got the posterior fibers. So this posterior part, right? The posterior part of the shoulder, right? That is, its cutaneous supply is by those dorsal rami of T1 to T3. Just keep this thing in mind. The moment we'll be discussing its application, you'll come to know the importance of it. Okay, so let's move on to something which you already know. Now at this point of time, you should be able to identify all these muscles, right? All these muscles. So let's say this is 1, deltoid is 1, supraspinatus is 2, infraspinatus is 3, teres minor is 4, teres major is 5, and subscapular is 6. I give you 15 seconds and can you identify all of them, right? Deltoid should not be a problem. So if you say this, it is correct. That is deltoid. Supraspinatus, yes, it can be seen. So there is supraspinatus. Where is infraspinatus, right? Well, infraspinatus is not seen. It will be on the back side, right? So completely fine if you have said that. Then teres minor and teres major, right? Where are they? So you know this, right? Figure out where is teres minor. That is over here, this small one. And where is teres major? Just underneath, right? That's the teres major. Good. And finally the subscapular, no doubt about it, that's the subscapular. So thus you know the muscles which are over here, right? No problem. Okay. So here is our deltoid, right? Done? Good. Right? So here is the deltoid and we are dealing with the anterior deltoid. Now see, as I was discussing, right? I'm discussing with so many students since 2 days. One common question is how to take the notes, right? How to take the notes, how exactly to write. Now, in fact, notes are already with you. How come? Right? Say for anatomy, right, BD Chaurasia is a very good book. Now, what you do is when you when you discuss or when you learn this particular topic, that if you open first you understand this entire session, right, and then when you'll open that BD Chaurasia, right, you'll find that all the keywords, all the points, they are already mentioned, but some of the structures or some of the explanation, if you don't find it proper, over here will be actually drawing those structures. Plus there would be few figures which will be drawing by our hand, and second, you will also draw it parallelly when we'll be discussing, right? So keep few paper, few colored pencil ready with you, right? If right now, if it is not there, even just one pen is enough. Second important thing, when I say that try to identify the structure, yes, do it, right? Do it effectively. So that will keep on enhancing your learning abilities. Okay. Half notebook is full. Very nice. That is very nice. And trust me, from next time onwards, I'll be giving you so many figures, right, that your rest of the half of the notebook will be finished within just 2 sessions. Okay. All right. So here it is. Now we know this bone. This is clavicle, right? And in clavicle, that's the lateral end. And we'll see that, yes, deltoid is a lateral muscle, right? So it is the lateral 1/3. Mark this 1/3 because that's what everyone would be missing. And that's the lateral 1/3 of clavicle. So how will you do it in that? In your books, actually the BD Chaurasia, right? It is a very good book if you learn it very systematically. So what you have to do is take a marker and you have to just highlight, right? You have to just highlight 1/3 because rest of the things you will not forget. Chances are that you this 1/3 portion that might be forgotten when the entire information will keep on piling up. How will you revise? During revision, any of the highlighted thing will come to you instantly. See, that's the point where the chances of mistakes are there, right? And you'll see, I'll give you one very good example as we proceed, right? Something which is about the that rotator cuff muscles. So I'll tell you how to write. The moment you'll be putting that habit into practice, there are no chances of error, right? So here it is the anterior deltoid. Yes, it can be seen that this is the anterior deltoid, right? And obviously, this is the middle deltoid. Now in middle deltoid, there is some speciality. And what that speciality is, that there are tendinous septas, right? Tendinous septa will actually draw these septa, right? So how many are there? There are 4, right? In the middle one, yes, only in the middle one. So let's draw it like, say, 1, 2, 3, 4. You don't have to be very artistic, right? You have to be scientific, right? You have to be scientific. So these are the tendinous septa. When there are tendinous septa, right, so it is like it is giving multiple wings, right? This is also called as the multi-pinnate muscle, right? This is multipinnate muscle. It is the middle deltoid which is multipinnate muscle. Why multipinnate? It goes something like this, right? It will be forming, right, like this, right? It will go like this. But where is it going downwards? Just wait, right? We are coming to that. But at this point, remember it is going like this. Now, what's the advantage? Remember one very powerful principle. The strength of the muscle is dependent upon number of fibers and not the length of the fiber, right? If the length is very big, yes, it has got the longer action, right? It has got the longer action. But if more number of fibers, so when more actin myosin filaments they contract together, it gives power. So that's the reason that this middle deltoid is actually very powerful. This is the reason, just tell someone that your hand is like this, apply the pressure and try to raise your hand, and then when you try to raise your hand like this, right? In many of the serials, right? In one of the serial, they say, okay, Daya, darwaja tod do, right? So he used to break the darwaja from his middle deltoid because it is so powerful, right? So that's why when you want to break the door, you use that middle deltoid, right? It is because it is so powerful, right? So this is the multi-pinnate muscle, and that's why we just remember more muscle fiber. So it gives higher strength. Now by doing this, these tendinous septas in between, so within less space you are increasing, right? The space is less, but you are increasing the surface area by providing all these septas in between. So thus it gives what's called as the strength. Okay. So here is our strength part. Okay. Very clear, right? This is the posterior deltoid. By the way, where is it attached? It is attached at the acromion process. Perfect, right? You don't need any introduction about the acromion process because right in the beginning we said where is acromion process? Touch here. That's the topmost structure, right? The topmost structure is acromion process. So clear, right? Now we go back. This acromion process, you know it very well that it was taking turn, and it on the back side it was going to spine, right? It was going to spine. So here is the spine, right? That's the spine. Spine of scapula, correct? Spine of scapula. Now this posterior component, this one is posterior deltoid, right? That posterior deltoid is attaching itself on crest of spine, right? So here is the spine. That one is deltoid. That one is acromion, right? Acromion process. So perfect, right? This is on spine. Okay. Now we go for that what's there regarding the insertion, right? Where is it inserted? As such, it's a sort of attachment, right? So insertion, obviously it is going on that humerus. Now this part of humerus, right? This part of humerus, because such an important muscle is getting connected, so humerus also respects that muscle, and that prominence, it is named after the deltoid, and it is called as the deltoid tuberosity, right? Deltoid tuberosity. Say, that's what I was telling. Say, we'll be talking about it, but right now first understand the whole thing, right? And then say you compare this entire thing with the BD chorusya, right? You'll find that yes, that's what I really want, right? That regarding the complete understanding parallel with what is given in the books and how to highlight all those so that always remains with us. I don't mind, I'll give you this also, right? It is completely fine, no problems. But I don't want you to be completely dependent. It's like explained, things should be into your mind so that you can actually apply it. Otherwise, yes, you will get it. Right? You will definitely get it. I'll be giving you this. But in that process, right, because I'll be giving you, don't stop writing and don't stop drawing, because I'll be telling you to draw something. So right now, take it that way. I'll not be giving you it, right? So you draw something when I say, but yes, you will get it. Surely you will get it. Okay, now let's draw this, right? All of you should draw this, because once you will draw, the complete concept would be clear. How many septas there were from the acromion process? 4. So 1, 2, 3, 4, right? You draw this. And then this is the deltoid tuberosity, right? So that deltoid tuberosity, there are 3 septa. So 1, 2, 3. Okay? See how interestingly things are made. These fibers, they now go like this. See, that's how they go. Okay? That's how they go. And see, it gives such an amazing strength. Technically speaking, 4 septas, right, they are taking power. Those 4 septas, they are transferring that power to 3 septas. So obviously the focus, the force would be focused completely concentrated at one point. That is what gives tremendous mechanical advantage, because here is the large surface area, right? This is a large surface area and focused to that small deltoid tuberosity. That's the reason that when you do like this, right? When you do like this is tremendously powerful, because such powerful muscle that is moving. Okay? So this is the reason why there is so much of power. So that's what is called as the deltoid tuberosity and the mechanism why this muscle is so powerful. And think it that way. What if something goes wrong to this muscle? This is a chief muscle. If anything goes wrong to this muscle, yes, that entire power is lost. Not only that, that rounded contour, right? Because this is a bulky muscle. Because it stays into the form of contracted state, that's why it gives a nice contoured shape. When this muscle becomes flaccid, right? So that shape, that round contour shape is lost. Okay. Now here it is. There is one nerve which is going, right? Just by looking at it, if I zoom it, just by look at it, if I ask that which cord is there, this one is which cord? And you know that this, three roots, right? They are combining together, right? In fact, these are the 3 divisions, right? 3 divisions. So 3 divisions they are combining. It has to be posterior, correct? It has to be posterior cord. Very nice, right? Now parallelly, if I ask that lateral cord, it was having how many divisions? Lateral and medial, we don't remember, but 1, 2, 3, 4, 5, 6, 6 alphabets. 1, 2, 3, 4, 5, 6, 7. Okay, this is more, right? This is 1, this is 2, this is 3. True. So these are how the cords are there. And because all these 3, that is like going in the form of posterior cord. True. Now in posterior cord, name itself is telling that it is posterior. Right? Name itself is telling that it is posterior. That means this entire complex, it will take the entire complex onto the posterior side. In posterior, that's the beautiful nerve which we have been talking about, and that is the axillary nerve, right? Axillary nerve. This axillary nerve, its speciality is because it winds around the surgical neck. We have been talking so many times. It winds around the surgical neck and it goes into the posterior compartment. There is one more, yes, there is one more artery which is associated with it, right? That was posterior circumflex humeral artery, right? That's how we were remembering it is like say Akapaka, right? AC, anterior circumflex humeral artery, posterior circumflex humeral artery. So it is this posterior which will be accompanying axillary nerve, and it will go on the posterior side, right? Anterior will obviously go from the anterior side. Okay, that is done. And then this is also one now, right? It is going all the way, and that is also bound to go on the posterior side, but with a special groove, right? And that is the radial nerve. And radial nerve will be enjoying its position into that radial groove, right? It's a big nerve, so it will tell humerus that show some respect, give me a special area. So humerus would say, okay, fine, a complete groove is prepared for you, and it will be passing through that, right? So all well. Okay, so that's the axillary nerve. This axillary nerve, see, it is going posteriorly. Now this particular system, this particular area is very important. Why? Because here is the deltoid, right? So for any of the intramuscular injection, we need to be absolutely careful that we don't damage this now, because it will be taking turn and then it will be coming from the opposite side, right? So always give injection into that middle deltoid, right? When you give injection into the middle deltoid, the chances of injury that becomes minimal. That's the reason that muscle is hold like this, and then the injection it goes. Now say as this particular nerve, when it is damaged, right? When it is damage axillary nerve. Why? Just fracture, right? Over here, if there is fracture, if this is fractured, so it will lead to the damage to axillary nerve. In such case, what would happen? First, we have already talked about. And what's that? That is that round contour is lost, right? Round contour is lost. Second, deltoid is so powerful, right? So it was doing like this, right? What is this? This is shoulder, and then it is going away. So we'll call it abduction. Adduction is coming near, abduction is going away, right? So this is abduction. So that shoulder abduction, that itself is lost, right? Shoulder abduction is lost. The third thing, this is interesting. The third thing is that there would be, say this is shoulder, exactly that lower half of that cutaneous area, there is a sensory loss. Sensory loss, right? That is on the lesser or the lower half, right? That is lower half into the deltoid region. Okay? And there is a special name given to it, as if it is a badge, right? Regimental badge, that is the name given, right? So it is like a regimental badge, because in any of the uniform, when you see the badges which are there, they are like over here, right? So the moment you hold your say arm like this, that's the area of sensory loss, the lower half of deltoid, right? So that is what is called as the regimental badge. Good, right? Everything is so simple, right? Just understand what it does, because here deltoid would be completely affected. Okay, now let's trace this axillary now. Say as we go, now we are watching it from the lateral side, right? Say this is the lateral side, and see how the this axillary nerve is trying to come out, right? And here is our posterior view, right? We are watching it from the posterior aspect, and here it comes. Yes, it would be accompanied by our posterior circumflex humeral artery. True, right? So both of them, they will be coming out. About the actions of deltoid. Now this is very easy to understand if you keep on doing all these movements parallelly, as I explained, and you just touch and you feel that yes, is it happening, and then it will click in the mind. How will you make notes of it? Just do it like this. Okay, I'll write it here. Say deltoid, right? You know that there are three fibers, right? This is what is called as the brain mapping. Otherwise, it becomes very confusing, right? So you'll say anterior, right? This is middle fibers, and these are the posterior fibers, right? Not the lower. We'll just write posterior fibers. And in anterior, the first one which is coming up is M rotation. Just this much. Keep medial rotation. Obviously, it is over here, so it will be leading to medial rotation of arm. So then why to write arm, right? It is self-explanatory. So I would write even less. How I would make these notes? I'll make it like this. For medial rotation, I'll say this, and I like this. This is medial rotation, right? So in my entire anatomy notes, wherever there is lateral rotation, so it would be like this. Wherever it would be medial rotation, it would be like this. M, and then this is medial rotation. L, this is lateral rotation. Gradually, you'll start developing such symbols, and they'll be very useful when you'll be making more and more notes, because then it would be like your trademark, right? You will be able to understand it very crisply. Okay, so this is the medial rotation. Now it should click, it should freeze in your mind. Touch over here and then rotate. See how the muscle is contracting. You should be able to feel. Just move your hand, right? Move that medial rotation and you'll be able to feel it. You have to actually feel the muscle. When you feel the muscle, it clicks, right? You always remember. Got it? Okay. So that's the medial rotation, the first one. The next, again, we are dealing with, say, anterior deltoid actions only, right? And what it is doing, say, transverse adduction of shoulder, right? It means, think it like when the deltoid, that is the middle deltoid, has already taken the hand like this. So when anterior contracts, it will do the adduction. See how interesting, right? How interesting. When the medial, that is the middle muscles, not the medial, I'm sorry, middle, right? When the middle muscles, they are contracting, it is taking the arm in abducted form, right? Abduction, right? Middle muscles, they are taking it away, and anterior, when they contract, so they are getting it back, right? So here it is, the second one. So first was medial rotation, and this is, say, adduction. For adduction, again, you can always write it like adduction, right? Adduction. It means, and about shoulder, now that is self-explanatory, right? You know that we are dealing with the shoulder, so no need to write, it has to be shoulder. So within just this much you have written, you have understood two major movements, right? Let's go further. Now, when the hand is like this, when the shoulder is like this, yes, it takes it back. But when it is inside and now the muscle contracts, so it will do it like this, right? It will be flexion, correct? This is contracting, so this is flexion, right? So third movement, right? One was medial rotation, then it was adduction, and then just this much is flexion, right? These are the three major important movements of the anterior compartment. Now what you do is just try to do all these movements, right? Just put your hand and move medial rotation, yes, feeling it, right? Then over here, so when it comes back, right, when that is the adduction, yes, that muscle is very powerfully felt, And then just put your hand, and then when you flex, just move it and you will feel the prominence, right? Immediately you will feel it. You will never forget it, right? So these are your notes. When it is said that how to write, but this is how you have to write, and you will just write it like anterior, right? That's it. Okay. Moving on to the middle deltoid. Middle deltoid, yes, we know this part is just the reverse, and that's we have already abducted, right? So adduction, now onwards, when we'll say like this, so this is abduction, right? It is minus, it is decreasing, it is going away, right? So shoulder is going away, so this is abduction. Then the posterior deltoid. So posterior deltoid, yes, this is lateral rotation. So now see how easy it has become that when we talk about deltoid, right, its anterior fibers, that was the medial rotation, that was the abduction, and what it was doing the third one, right? What was that? What was that? Right? It was flexion, correct? Regarding the middle fibers, what it was doing? Abduction. So this is minus abduction. It is going away. And for the posterior fibers, right? If this was medial rotation, that would be the lateral rotation, right? So just put your hand back, and the moment you'll rotate your hand laterally, yes, right? Right? It will happen it like this. Okay. Next is posterior deltoid shoulder extension, right? Shoulder extension. This is shoulder flexion, right? The anterior, it is doing shoulder flexion. So that what posterior would do, right? Posterior would take it back. So that is shoulder extension, right? This is flexion, right? And then this is extension, or even hyperextension. So when you are taking shoulder still more back, it is called as hyperextension. So here it is shoulder extension and shoulder hyperextension. Extension will write like this, and hyperextension will always write like this because it is extra, right? So it is hyperextension. Perfect. So that's how you'll be able to handle it. The finally shoulder transverse abduction. Yeah. Abduction was already handled by middle fibers, right? But now it is also taking this into action because it is the posterior fiber, right? So when it is, but this time it is not only the abduction like this, it is transverse abduction, right? Transversely you are going. So it makes sense. The hand would be, the shoulder would be going like back, right? Abduction. And the hyperabduction, right? So from this level, and then it can go still back, right? So that is hyperabduction. Okay. Let's focus now to our second muscle, right? This second muscle, just by look at it, you will know that this is supraspinatus, right? No introduction needed, supraspinatus. But in this, once again, our focus would be that it is the supraspinous fossa. Yeah, that is the supraspinous fossa. That's where it is. And insertion is at the greater tubercle. Yes, that's the greater tubercle, right? Greater tubercle. And this greater tubercle, that's the point which we have felt. This is the lateral most bony prominence. True? Right? Lateral most bony prominence, that is what we really feel. So this is easy, supraspinatus. Right. Now that's infraspinatus. Right. Infraspinatus. So again, that is the infraspinatus fossa. And its insertion, again, it is at the greater tubercle. Now there is something extra, right? There is something extra. What's that? this one, the upper supraspinatus and the middle infraspinatus. It means we are focusing on this area. Focusing on this area. So we have this one, supraspinatus, and then middle one, that would be infraspinatus. So here is the middle one, this is the infraspinatus, and the superior part over here, right, that is supraspinatus. Correct? Male, anyway, I'll see that. Got it? So these are the two important things which we need to know, supraspinatus and the infraspinatus. Now when we talk about, say, this supraspinatus, what it can really do, right? What it can really do. As such, just have a look at its direction. Make a wild guess. What can it really do? When this muscle contracts, right? So it will take the arm up, right? When it contracts, right, it will take it up, correct? So it is like it is supporting the deltoid, right? It is in association with the deltoid. So what it is doing? It is taking it up, it is taking it away. So this is like someone who will be helping in the abduction, correct? Because it is situated on the top, and whereas it contracts, it will take it up, right? So it will be supporting abduction, right? That's what it will do, supporting abduction. Now, there is one more point which we need to remember. This will immediately start integrating the nerves and the muscles. One is, who will supply supraspinatus muscle, right? So supraspinatus muscle is by suprascapular nerve. Now, where is this suprascapular nerve? Where is this, right? Go back to our brachial plexus, C5, C6, true? They were like roots. These roots, they were forming the trunk, right, which was the upper trunk. This suprascapular is emerging from there. So that is where it will come from, right? So we'll say suprascapular. Now what would be its root value? C5, C6, right? Because there is no one else, C5, C6. So it will supply this supraspinatus. Then, just because we are just dealing with it, there is one more nerve which was supplying a very chota sa muscle. Which was that? One more nerve which was coming up, and it was supplying a very small muscle hidden underneath a bone, but its importance is very good because it was supporting our brachial plexus. I am giving you the clues. It was supporting our brachial plexus. It was supporting axillary artery, right? Hidden underneath a horizontal bone. Yeah, that is nerve to subclavius. Correct. Nerve to subclavius. Okay. No, right? This was nerve to subclavius, right? The subclavius, yeah, subclavius, which is known to steady the subclavian, which is known to steady the clavicle, which is known to give support to our brachial plexus and the axillary. Okay, over here. Now, this muscle, when it would contract, when this muscle would contract, it will lead to, right? It will lead to lateral rotation, right? Lateral rotation of the arm, because it is onto this plane. So when it contracts, it will lead to lateral rotation. So that's lateral rotation of arm. Good. So that's how these muscles are supplied. Regarding the nerve supply, regarding the nerve supply, again, it is the suprascapular nerve. Now this is so clear that this is suprascapular nerve. It is supplying supraspinatus and infraspinatus. So now onwards, when you'll be revising your brachial plexus, at that point you will immediately write it like that, okay, this is the upper trunk, right? This is C5, this is C6, and here is the upper trunk, and this is the suprascapular nerve. Suprascapular, reflexly you will say that it would be supplying supraspinatus and infraspinatus, and parallelly take that nerve to subclavius also. So this is the subclavius, and just speak of that this is the muscle which is just underneath the clavicle which will be supporting, and now you know that. Okay, by that way, if I'm asking this question, let me ask you one more question. Through which two muscles the subclavian artery along with the brachial plexus it comes out? Through which two muscles, right? There is a window created by two important, I have already drawn it, right, to give you some idea. And name of these two muscles, they are quite similar, right? So things, they come out from in between these two muscles, right? Which muscles are we talking about? And then there is similar name, there is the third muscle also, but it is posterior. So I have already given you the answer. Which muscle are we talking about, right? Which muscle are we talking about? In other words, through which two muscles the subclavian and the brachial plexus, they come out? Teres major minor. If it is teres major minor, think it of that subclavian is where? Subclavian is just here, right? Subclavian is just here, because after the first rib, right? When do you start telling that subclavian is now axillary? Wait. It is not teres major minor, right? It is not teres major minor, because if it is teres major minor, see, I gave you the hint. There is a third muscle also with similar name. Now, there is nothing like teres major minor and teres minimi, or right, nothing like that. And this we are dealing with neck, right? From neck. Wait. Right? This is, think of, just answer this question. At what point, no triceps, so how can the triceps be? Think of, triceps is just posterior, right? Triceps is posterior. If the triceps is posterior, we are dealing over here, right? Think, triceps is here, right? We are talking about here. Triceps will never overcome over there, right? That's right. That's what you said is very correct. That is the after lateral surface or the external surface of the first rib, the name changes. The subclavian becomes axillary. Now, where is first rib? It is just here, right? Just here. So you are dealing with neck. These are the muscles which are called as the scalenus, right? Scalenus anterior, scalenus middle, and then there is scalenus posterior, right? These are the scalene muscles, scalenus anterior, scalenus middle. In between scalenus anterior and middle, it comes out. But the best part is, those who have even attempted the answer, now you will never forget this, right? You will always remember that it is the scalenus, right? Anterior, middle, and the posterior, right? No worries, such things happen. And that's what I said, that this is your home ground. Make as many mistakes as possible, right? Because when you make mistake, it means you either win or you learn, you never lose, right? And it was told by one of you guys only. So that's why I always repeat that. Okay, let's move further. Here it is. Yeah, see, teres minor, right? This is the teres minor, right? That's teres minor. True. See, rib was over here, right? And this entire structure which we are dealing, it was coming out from this point, pretty far, right? This is teres major, right? This is teres major. This is infraspinatus. Yes, you know that, right? And this is our traps, yeah, trapezius, right? So that's the traps. So over this point, teres minor, right? Origin upper two-third dorsal surface of lateral border of scapula. Well, can we really see it? No. But insertion, yes, greater tubercle, lower part. Now the mystery is solved, right? See, greater tubercle, right? This is the lower portion, right? We dealt with the upper one, we dealt with the middle one, and now this is the lower one, right? So this is the lower where it is inserting teres minor. And obviously, right, these two, though they were easy. See, here it is. This is the supraspinatus. This one is infraspinatus. And that is teres minor. See how logical. True? Yeah, that's true. That's what is called as the spaced repetition. So every 3 day, right, you just go through. Now, let's say if you write it like this, not much, but the upper supraspinatus, inner infraspinatus, and lower, always write teres minor like this, T small and MN, right? T should be written like this. So wherever T is like this, it means teres minor, and wherever it will be teres major, you'll write it capital. Importance, just within 2 minutes, you'll come to that, right? So this is clear, right? That's where we started, that this is our greater tubercle, lateral most border free. You just touch over here, close your eyes, and then you know that upper it is the supraspinatus, middle it is infraspinatus, and the lower it is teres minor, right? Revision is automatic. Okay, that's the teres minor, and now we can see it with much better clarity, because when we said that it is the upper two-third, yes, now it is seen that if this is the lateral border, this is the lateral border, right? That's the lateral border. So upper two-third, yes, that's the upper two-third. How nice, right? This is now no problem, right? That's how the teres minor is connected. True? Teres minor, right? What it will do? See, this is as good as this infraspinatus. We deliberately removed infraspinatus so that we can have a clear visual of teres minor. So infraspinatus was lateral rotator. So this teres minor is a chota sa muscle. It is also doing almost the same thing, right? Because both of them, they are attached over here on the posterior part. So it will also lead to that lateral rotation of arm. Now this should give you one clue that many of the movements, right? There are some major movements like deltoid, right? Pectoralis major. They are powerful muscles, but they are always supported by these chota muscles, these small muscles. These small muscles, they give the proper control, right? So when the power is needed, those big muscles will come into picture. But when it comes to the delicacy, so it is there where these small muscles, they will be adjusting the complete fineness of the movement, right? So that's how the entire system is actually working. Regarding this teres minor, it is supplied by, now see, this is a posterior part, right? Who is very near? Axillary, right? Axillary is coming just out. If can you see this? Here is axillary coming out. So axillary would say, because I am so near, I don't mind giving you a branch. So it is supplied by axillary nerve. The moment it is said axillary nerve, it should come in your mind, axillary nerve, branch of posterior cord, and that posterior cord, it will be continuing as radial nerve, right? So these things, they should go like a sequence. Gradually it would happen. It will not only create a picture, but at the same time, you will never forget, right? And where is this nerve? Here is this nerve. It is going posteriorly? Yes, it is going posteriorly. And this is that groove. This is that groove, right? Tomorrow we'll be dealing only in bones. Tomorrow we'll be watching only osteology. Every bone, right? All these bones, scapula, clavicle, then humerus, right? We'll be understanding in depth. So I'll show you all the grooves, all the tubercles, everything. So, but when you know that, yes, on the shaft, right? Yes, it is fine tuning, right? On the shaft, there is a complete ridge, and that is for the royal radial nerve, right? Which is traveling posteriorly. Okay. So here is now teres major. This teres major, if I say the first thing, teres major, where was it inserted? Well, it was, we said that lats between two majors, right? You remember this? Right in the beginning, we talked about that it is the pectoralis, pectoralis major. Where it is connected? It is on the lateral border, right? It is on the lateral border of that bicipital groove, right? On the medial border, what is there? It is this teres major. So two majors, right? It is the teres major, right? And in between it is what? In between it is the latissimus dorsi. Okay, now our area of focus right now is teres major. This teres major, right? It is doing what? It is going right, and then it is going on the anterior surface and it is connecting to the medial lip. So when it contracts, right, obviously it will lead to what movement? It will be a medial rotator. Got it? Right? Because when the muscle, it is connected here. It is connected on the medial aspect, right? Coming from the back. But when it contracts, it will take the hand like this, right? It is like this. When it contracts, it rotates, right? So that's what it really does. This is the medial rotator, right? So now we can we write it like it is the medial rotator, right? Medial rotator, because it is connected on the medial border. So when it contracts, it will take it inside. Okay, so that's its very important movement. It is supplied by, well, it would be supplied by, now this supply is very important. It is a major one, right? Teres minor was getting a royal treatment from the axillary, right? But this teres major is not getting anything from the axillary. From where it gets, right? It will say, well, you will be supplied by one special nerve, and that is lower, right? There was suprascapular. Now this is lower subscapular. Now if there is something like lower subscapular, it means there has to be the upper subscapular also. True? And these muscles are posteriorly situated. So nothing doing, it is simply the branch of the posterior cord, right? So how come? How come? Okay, let's do one thing. Take a piece of paper, right, and draw along with me, right? Parallelly draw along with me. At any point, if you even lag behind slightly, immediately let me know, right? But you draw along with me. We finish the entire brachial plexus in just 3 minutes, right? So start drawing it like C5, C6, C7, C8, T1, right? In between, I'm just doing like this. These are what? These are vertebrae, right? These are vertebra. These vertebra are like C5, C6, C7. No, it is not C8 because there are only 7 cervical vertebra, right? So this is T1, T2. That's the reason that there is a special name given to C8, right? The rule was that in case of cervical vertebra, the nerve would be emerging above the vertebra, right? So it would be emerging above the vertebra. And in case of thoracic, it would be emerging below the vertebra, right? So that's why T1 is emerging below the T1 and C5 is emerging below the C5. Correct. So that's why C8 was not having any name because it was not falling in any of the category. That's why it is given C8 name. Okay. Right. This is something which we have discussed at length when we were talking about brachial plexus. Now start drawing. Right. Just write it like root, trunk, division, and cord. Correct. So this, this, and this. So you know now this is upper trunk, middle trunk, and the lower trunk. Upper trunk, don't waste any time. Immediately you know what I'm talking about, right? Upper trunk, because it is only the upper trunk which is giving these branches. Otherwise, rest of the two trunks, they won't be giving any branches. This is going up, so we call it supra. Right? Supra what? There is only one scapular region, right? This is suprascapular nerve. Good. And then this is nerve to subclavius. Excellent. Right? This is nerve to subclavius. But this portion is done. Now divide them. Right? This is anterior, posterior, anterior, posterior, anterior, posterior. Right? These are what? These are the divisions. Right? These are divisions. These are division. That was trunk. These were the root. And that was the cord. Okay. Now anterior, posterior, anterior, posterior. So if you wish, you can write this AP, AP, AP. Otherwise, no need to even write. Join top to, so it will lead to formation of, yes, you are very right. That is the lateral cord. So this is the lateral cord, right? This will go straight. So that is what? That is the medial. Just wait. Draw it like this. Draw it like this. Yeah, this would be interesting, right? So this would be the medial, and when all the posteriors, they will join together, that will lead to posterior cord. Correct? Posterior cord. Now let's finish the posterior cord first because we have talked about it so much. So straight away just push one. This is what? Axillary, and it is the axillary which will be winding around. Winding around, you are right. Winding around the surgical neck of humerus, right? And it would be accompanied by that PACA, right? Posterior circumflex humeral artery, right? And then it will continue as, yes, that royal radial, right? Royal radial nerve. So done. But remember, we just talked about something, right? We talked about upper and the lower subscapular. True? So let's draw this, right? So they are subscapular. So draw them down. So this is subscapular, right? Subscapular. This one is upper and this one is lower. This much would be enough, right? It will give you a good clue. And then in between there is thoracodorsal, right? Thoracodorsal. Done. 90% of it is complete now. Rest is so easy. Divide. This lateral will give one important branch, and in fact it is very important. It is the musculocutaneous, right? And then this is what? This is the lateral root, right? Someone asked this question that whether it would be the lateral cord or lateral root. This is lateral root which will be joining the medial root, correct? Which will be joining the medial root, and they will form what? They will form median now. So that's why in reply I wrote this thing in capital, median, not the medial, right? This is the median now. And finally, anything left out? Well, this medial cord, right? It will go and it will make what's called as the ulnar nerve. That's the ulnar nerve. True? Now, add something to this, that who is actually continuing. So this lateral cord, right, it is actually continuing as musculocutaneous now. So it means that lateral root is a smaller one, right? Lateral root is a smaller one. However, in case of the medial cord, you have to draw it like this. This means what? It is the medial cord, right, that will continue as a medial root of median now. So who will be giving more, say, contribution to the median now? It is the medial root, right? And the ulnar will be thinner. And how about, say, this posterior one? Well, no doubt about it, right? This will be going, obviously, our royal radial now. Now, if you have drawn this figure, right, this gives you complete clue. Everything whatsoever is needed, it is over there, right? Because when you will be discussing that what is Erb's palsy, yes, you will be dealing with that. This is the Erb's point, 1, 2, 3, 4, 5, 6, 6 nerves meet over there, and then it leads to that Erb palsy, etc. Right? That policeman tip or the or that shoulder, that waiter tip injury, that porter's tip injury. Okay, done. This much you have drawn properly, right? This figure, right, you every day you just draw it once without watching, right? First you draw along with, and then try to draw without watching. Do it 3 to 4 times, and you will remember it, right? And every 3 days, 4 days you keep on repeating. Then gradually that repetition can be even more spaced. Initially you are doing it every day, right? Then you start doing it every 3 days, then 1 week, and then to even if you draw it in 1 month, then also you'll be able to remember. After some time, you don't have to remember. You'll just look at it, give 5 seconds, enough. That's your notes. These are your notes, right? Yes, Klumpke's palsy. That was also the second. Good. Okay, let's move further. So here it is. From this point onwards, you'll find that things are so easy, right? Because everything will fall into its correct place. This is subscapularis, right? You know this. And its origin is subscapular fossa. Yeah, no doubt about it, right? We know this. And insertion is lesser tubercle. Yeah, this is the lesser tubercle. That's the lesser tubercle. Because greater tubercle was the lateral most bony prominence. True? Okay. Now see these tubercles. As such, can you just feel that these tubercles, they are surrounding this important shoulder joint, right? Important shoulder joint, right? That's so when I say this, that what it will do. So when this subscapularis contracts, right, it is right like this front. So when it will contract, it will lead to medial rotation, right? It will lead to medial rotation. True. So that is the medial rotation. True. And what about the supply? Well, it is the subscapularis, right? If you see over here, this was what? This was Teres major. That's okay. Name is major, right? Name is major, but it is supplied by lower subscapular nerve, right? Name is major, but it is supplied by subscapular, lower subscapular nerve. See the difference, right? How the partiality they do. Subscapularis will say, my name is so important. So upper and lower, both subscapular nerves, they will supply me because we share common name, right? So that's what it happens. And now from where this upper and lower subscapular nerve, immediately you'll say that yes, this is from the posterior cord, right? The posterior cord which was giving 3 branches: upper subscapular, lower subscapular, and then there was one which was coming in between, right? And that was thoracodorsal, right? So that way indirectly you have remembered that thoracodorsal dorsal also, right? Excellent. And this is like medial rotator of the arm, right? Medial rotator of the arm. One more important point, if you look at it, this is also a multi-pinnate muscle. Multi-pinnate muscle. And now you know very well that what exactly is multi-pinnate, right? So it will be having all those tendinous structures and the muscles will be attached like this, thus giving more strength. See, just by look at it, you will know that yes, it has to be like this. See, such a large area and concentrating on a smaller area, right? So that's what it gives mechanical advantage. Okay. So structures which are under cover of deltoid, right? So this is easy. Upper end of humerus and the coracoid process, right? No problem. Muscles, which are the muscles? Just underneath the deltoid, right? Pectoralis minor on coracoid process, yes, right? Because pectoralis minor, so it is just underneath, right? Then supraspinatus, yes, infraspinatus, teres minor on greater tubercle. So here we are once again enhancing our that knowledge, right? That greater tubercle was divided into three parts: supraspinatus, infraspinatus, and remember over here we won't write it like teres minor. No, we won't write it like this, right? I'm erasing it. We'll write it like always teres minor, right? Later on, so we'll even write it like just this teres minor, right? But at this point of time, it's okay writing like teres minor. Always T should be small. Okay. Then one more important point. This is subscapularis. Yeah, big muscle, right? It is in fact this deltoid though is like a complete cover. And pectoralis major, teres major, and latissimus dorsi on the intertubercular sulcus, because that intertubercular sulcus, bicipital groove. So once again, this is what? This is that. This is that. Two majors, right? Two majors, right? Teres major and packed major, and between latissimus is latissimus dorsi, and this entire thing is into intertubercular sulcus or the bicipital groove, and this groove is covered by deltoid. This piece of information, this entire thing, it gives us that important idea that how the things are, because deltoid is absolutely like a cover, right? Okay. Regarding this origin, coracobrachialis and short head of biceps, that is from the coracoid process. So coracoid process, we talked about coracoid process, right? There was a bit of confusion between whether it is a short head of biceps or coracobrachialis. So we said that if this is the coracoid process, right, here is the short head of, say, short head of biceps, so then coracobrachialis is just underneath it, right? So it is just, I'm drawing it in yellow, right? It is just underneath it, correct? So this is done. Now you can't miss that. Who is connected to coracoid process? Yes, underneath coracobrachialis, on top of it, it is short head of biceps brachii. Then long head of biceps from the supraglenoid tubercle. Supraglenoid, wait, right? It will come. But just let's say supraglenoid. What is glenoid? Glenoid, right? It is that surface on which the head would move, right? The head would move. So that is what is called as the glenoidal cavity. Now, if that is the glenoid, this is the glenoid. Many times we have drawn this, right? That it is the humerus and it's how it moves, right? And this is a shallow cavity. It is shallow because in upper limb we require mobility, right? In lower limb we require stability. So this is glenoid. There is tubercle above, there is tubercle below. So obviously the above, it is called as the supraglenoid, and this lower one, it would be called as infraglenoid, correct? Now comes that mystery. This supraglenoid, so this is sure that we are dealing with sorry, we are dealing with the joint, right? This entire thing is a joint, correct? This is a joint. And so that this supraglenoid tubercle, this portion is also inside the joint. So that's where comes our very special guest of honor, long head of biceps brachii. It is this long head. Why is called long? Because it goes all the way into the joint, right? And lands on the supraglenoid. So because it is traveling so much, so we don't hesitate in giving it a name, long head, right? It is because it is traveling so much. Similarly, long head, right? Long head of triceps. Well, that long head of triceps is connected here, infraglenoid, right? So how musical, right? Long head of biceps and long head of triceps, they both are connected to that glenoid. Now see, that's the point. It means how finely, right, they both will be handling it, right? Biceps contracts, so that is handling the supraglenoid, right, area, so it pulls, and when the triceps contracts, so it will contract the lower portion. So that's how both of them, they are completely balancing each other. And finally, lateral head of triceps brachii from upper part. That we'll see, right? It has to be on the posterior surface because nothing big in that. Triceps itself is posterior, so it has to be on the posterior surface of the humerus, right? So that is okay. Vessels, anterior circumflex, this akabaka, right? Anterior circumflex humeral artery and posterior circumflex humeral artery. Yeah, they are around the neck. And if they are around the neck, deltoid will surely be covering it, right? So this is how it is to be understood. Okay. All right. Let's move further. This is where I was talking about that what it is, why you have to write it like this. As I said, just watch this. Yeah, this is what I was telling, that there is a greater tubercle and there is a lesser tubercle. Now these tubercles, see, actually they are inside, right? They are forming this shoulder joint, right? This shoulder joint, 1, 2, 3, 4 muscles are connected, right? So here it is, the 4 muscles collectively. Which are these 4 muscles? Here it is. 1, supraspinatus. This is 2nd, infraspinatus. This one, 3rd, that is teres minor. And subscapularis, this 4th one, right? That 4th one, it would be on the opposite side. Getting it? True, right? So supraspinatus, infraspinatus, teres minor, and the subscapularis on the opposite side. Collectively, these 4 muscles, so 4th one, that is subscapularis, they are called as the rotator cuff muscles, right? These are called as the rotator cuff muscles. They form 4 flat tendons. And these tendons, they are very powerful. So ideally, they blend, they mix with the capsule, right? They mix with the capsule, and thus it makes a very tough capsule. That's the reason that it gives tremendous strength. That's why your shoulder is very powerful, right? It gives tremendous strength. Now see, subscapularis, supraspinatus, infraspinatus, from there the teres minor, right? Everything is properly covered. But who is on the inferior aspect? Right? No one. That's the reason that whenever there is any shoulder dislocation, it will be on the lower side. It will be the inferior location, right? So let's see. So supraspinatus, infraspinatus, teres minor, and subscapularis. How to remember it? As such, you will now always remember, but remember it like SI sits, right? But write T like this, Supraspinatus, infraspinatus, teres minor, and subscapularis, right? We don't want any of the doubt that it is teres major or minor. Sometimes it happens, right? But when you start writing like this, you will never ever make a mistake that it is teres major, right? Always you will write it like this only. And this will prevent even the revision also. You'll just see and you will say that, okay. And here it is like, this is subscapularis, right? That's a subscapularis. This is supraspinatus. And here is the teres minor. True? Okay. So they support everywhere except this downward, right? Over here there is no support, right? Over here there is no support. So that's why the downward dislocation is so common, right? Downward dislocation is common, right? Makes sense. True? Because there is no support. So how will we really draw it, right? Say that's your humerus, correct? That's the humerus, and this is the process, right? That is the scapula, right? This is the scapula. So if I draw it with like this, so any muscle which is over here, right, it would be subscapularis, and any muscle which is over here, it would be either supraspinatus or infraspinatus. Now let's say if we are taking it at a lower level, so this is infraspinatus, completely easy, right? And then this entire thing is covered by, that shape itself is telling that it has to be deltoid, right? The deltoid. So that gives that curve. True? And then bus, that's it. There are just 3 muscles over here, and these 3 muscles, you know it so well, that this is pectoralis major, this is teres major, and in between you have got latissimus dorsi, right? So this is pect major, this is teres major, and that is latissimus dorsi. Now, where were they? They were passing through bicipital groove, right? Bicipital groove is carrying what? It is carrying long head of biceps. So where is biceps? It has to be there, na? So here it is. Here it is the biceps, right? Here is the biceps. So it is into the groove, and then the rest of the structures, they are connected on both the sides. So you just write it biceps. Friends, you have already taken a cross section. You have seen a cross section. This is nothing but a cross section. Now if I show you, right, the CT image of this, you will be able to identify very easily all the different muscles. Right now we are not doing it, but we'll do it. But remember, draw it like this. You need not be very sorry. You need not be very artistic, but you should be scientific, right? This is how you keep drawing. It will enhance the complete concept of it. Okay? All right. Let's move further. As we said, the rotator cuff muscles, right? So what exactly, how will they really be managing? So let's say if this is the humerus, right? This is the humerus. Then surrounding it, right? That is what is called as the labrum, right? That is the cartilaginous structure. Okay. And then it forms the complete capsule, right? That's the capsule. That's the capsule. Now in this capsule, obviously, over here it is all fluid filled, right? This is the fluid filled area, right? This is synovial fluid. True? Muscles, they are connected over there. Right? If I want to draw one more bony structure, it would be on the top only, right? And that is acromion, right? You are very right. This is acromial process. That acromion process, there is one more process, that is the coracoid, right? So humerus and acromion and coracoid, these are the main process, right, which are over there. Muscles, they are connected over here only. Which muscles? 4 muscles, and they are 6, right? Supraspinatus, infraspinatus, teres minor, and subscapularis. Now this subscapularis, as we know, subscapularis is anteriorly, correct? Subscapularis is anteriorly. So out of these two, Coracoid is anterior or acromion is anterior? Coracoid is anterior, right? Because coracoid is giving attachment to two muscles. What was the name of the deeper muscle? Right, that was coracobrachialis, because it was going right in the front, and next time when we'll be studying the arm, we'll see that coracobrachialis is straight away going like this, very important muscle. So this is anterior. If this is anterior, then let's draw one muscle like this. So this is what, no doubt about it, it has to be subscapularis. But once the subscapularis is there, rest of the muscles, they are completely easy, right? There would be a spine, right? There would be a spine. So the spine, if it is here, so then we call this as supraspinatus, and anything below it is the infraspinatus. And after infraspinatus there is teres minor. This combination what you just drew, right, that is nothing but it is called as the rotator cuff muscle, cuff muscle, right? It is just forming a complete cuff, right, giving the strength. And as you know, right, as you see, there is no downward support. That's why the dislocation on the lower side is very much common, right? So that's what you saw. One more thing, in case if you want to draw it, it is, if I draw anything like this, right, and which is just connecting over there, passing through the entire capsule, right, it can nothing be but long head of biceps, correct? Long head of biceps, because it is going all the way over there to connect. Good, right? So that's the important thing. Now, as we are discussing this is a acromion process, right? Why cuff? Because of its shape, right? Because of its shape, it actually captures it from all the side, right? Cuff is what? That hatkadi, right? Actually, it is like hatkadi, right? So cuff is always formed like this, because over here, so there would be the lock, correct? There would be lock. Actual hatkadi is this much. So this is the natural hatkadi of shoulder, right? That's why cuff. Okay. Now we are talking about that whenever the bone, right, bone moves, right, it leads to friction. Whenever there is friction, it leads to pain. So what has been done is that there are some areas where fluid filled cavities are kept, fluid filled sac, right, fluid filled, those capsules they are put. So they are fluid filled bags which will be acting as a shock absorber, right? They release the friction, they remove the friction, and they are called as the bursa. Bursa, B-U-R-S-A. Bursa is nothing but it is that fluid filled sac. Why we are discussing it right now? Because this is the body's largest bursa, this one, largest, right? So it is called as it is just underneath the acromion process. So it is called as subacromial bursa, right? It is called as the subacromial bursa, right? Easy to remember. Then, but important, it is the largest in the entire body, right? This is the largest one. Why it is named like that? What is named like that? No, I'm not getting the point. Means Bursa. Bursa is, Bursa word. Yeah, Bursa itself means something which has got thin wall and it is filled with fluid, right? That's the meaning. Okay. So it acts like a cushion. I think the another meaning of Bursa is also a cushion. So maybe because they act like a cushion, so that's why they are called as Bursa. Okay, now one or two important ligaments. Ligament Always remember it is bone to bone, right? Bone to bone. That is ligament. Their function, there can be only two functions. One, it gives stability, and second, it gives strength, right? They play crucial roles. The best part, the name is always suggesting from where it is starting and where it is ending. Coracoacromial. No need to say further. Starting from coracoid process, ending on acromial process. Yeah, here it is coracoid process. Here it is the coracoid process, and here it is the acromial process. And that's the coracoacromial ligament, right? And when we see that this subacromial bursa, right, where it is, okay, here it is. See, here it is the subacromial bursa. So this is deep to deltoid muscle in subacromial space. Yeah, it has to be because deltoid is like that. So it has to be deep, and it is for smooth movement of supraspinatus. Right? See, supraspinatus is here. Right? This is supraspinatus. So when supraspinatus is moving, right, this muscle should not be going against the friction with acromial process. So that's why a nice bursa is kept over there. Meantime, here is coracohumeral ligament, right? We are talking about this one. Name is suggesting starting from coracoid process and it is going on the humerus, so we call it coracohumeral, right? It's quite easy. Okay. See, that was the glenoidal labrum, right? So this is the supraglenoid and that's the infraglenoid, right? And here would be the head of humerus, right? And where exactly was it landing, right? So over here, it was forming the whole capsule, right? So whole capsule was getting formed, right? This was the capsule, right? That is the space, right? That's how the whole thing, and covered by deltoid, right? And over here, this was the acromion process, and this is the location of bursa. That's the location of bursa, right? So important. And this is subacromial bursa. There is one more bursa, coracobrachial bursa. Coracobrachial, coracoid process, deep to coracobrachialis muscle. That's the point, right? And it is overlying coracoid process. It has to be, right? So that when it is over there, it will prevent that friction. So this is meant for coracobrachialis muscle. So this is coracobrachial bursa. One more, subdeltoid, right? Subdeltoid. So deep to deltoid muscle in glenohumeral joint capsule. The point, smooth movement of rotator cuff muscles. And these rotator cuff muscles, they were what? SITS. S-I-T-S. Right? Supraspinatus, infraspinatus, teres minor, and the subscapularis. Right? About this quadrangular space, you remember we talked about quadrangular space, right? So these are like, say, looks wise, right? It looks so confusing, that superior, inferior, medial, lateral, right? Surgical neck of humerus, this, that, axillary. Now, no, we don't remember it like this, right? This is okay. That's the theory. How we do it, how we remember this? We remember it like this. That's how we remember, right? So first, your orientation should be proper, right? You take two fingers, right? And then just one underneath, one on the top, right? So the way it is shown, right? What it is forming? It is forming first one. Say, on which side are we dealing? Simply remember that this is what, that is humerus. If this is humerus, right? Don't make this mistake, right? Understand, this is humerus. if that straight line is, this straight finger is humerus, so humerus is always lateral. So this means I'll write this over here as lateral. This side is lateral. You are watching it from right side or left side? You are, I'm sorry, you are watching it from anterior or posterior? You are watching from posterior because we are discussing scapular region. So we are watching from posterior aspect. So this is the posterior view, right? When it is posterior view, it means with about which side of the joint we are dealing with. This is a left side joint or right side joint, right? Just reply. This is, yes, exactly. You wrote it like that. This is left. True. Because when the scapula, when the humerus, right? When the humerus is over here, yeah. When the humerus is over here and you are watching from the posterior side, right? So it has to be the left side, correct? From the back, correct. That's right. Good. Okay. Good, 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 very good. Right? So that is humerus. The topmost one, right? This upper one, this is teres minor. Now so we know it so well that this teres minor, that chota sa, it is always on top, and this one is teres major, right? This is teres major. And then these are, because it is the posterior part, so that's why we are dealing with the triceps. So in that case, humerus, and obviously this would be the lateral head, correct? This would be the lateral head of triceps, and if this is lateral, so then there is only one choice left out. This has to be the long head of triceps. So long head and the lateral head of triceps was done, right? So now this one is our quadrangular space, this one is our triangular interval, and this is our triangular space. True? So that is quad space, quadrangular space. This one is triangular space, right? Sometimes it is called as upper triangular and lower triangular, right? But in Gray's, many times you will see the word that it is triceps hiatus or triangular interval, or you can say the lower triangular space, right? It really doesn't matter, right? But this is how it is then. Now when we go back, right? So it is all very easy, right? Here it is our humerus, correct? Then this one is nothing but the lateral head triceps, and this one is the long head triceps. No doubt about it, this is teres major and this is teres minor, right? And here is what we are looking at. This is our quadrangular space. True. That's our triangular triceps hiatus or triangular interval, and this one is the triangular space, right? Good, all of them. Okay, to this over here, now this is the opposite side, right? This is the right side. So in the right side, right, this is the right side, we are watching it from the back, right? So here is again, right, how the things are arranged. This would be like, say, teres minor. This would be teres major, right? And these are the long, this is the lateral and long head of triceps. And that's how, say, quadrangular space, triangular interval, and the triangular space, right? This side is the right side, right? I put both of them so that you are properly oriented, right? Crystal clear that what exactly Yeah, triceps hiatus. So literally that how you are clearly oriented into this system, right? That's the opposite side, and that's how we remember. Okay, so when we deal with this quadrangular space, right? So subscapularis, teres minor, teres major, humerus, long head of triceps, right? Everything is completely clear that what it is really happening, right? Teres major, humerus, long head of triceps, and teres minor or subscapularis if you are considering it on the anterior side, right? Subscapularis when you are considering it from the anterior side, when you're watching it from the anterior side. Okay, what it is passing? Axillary nerve is passing through it. When axillary nerve is passing, it is passing along with that posterior circumflex humeral artery. So done. Quadrangular space is complete, right? See over here how easy it is, that this is the lateral side. So we'll say lateral side is formed by humerus. Yes, done. Medial side is formed by long head of triceps. Yes, that is done. Then inferior, right? Inferior surface is formed by teres major and superior is formed by the teres minor. All these four areas done. What would be passing through it? Well, axillary artery, axillary nerve along with posterior circumflex humeral artery. True? Okay. So quadrangular space, right? Axillary nerve passing through, and this is the posterior view. How we see the posterior view. Now upper triangular space, right? We saw that inferior border of teres minor, right? Teres minor, then medial border of this long head triceps, and the superior border teres major. That's how it goes. And content, circumflex scapular artery, circumflex scapular artery, right? From where it is coming, this circumflex scapular artery, right? And it interrupts the origin of teres minor, reaches. Okay, let's see this. Circumflex scapular artery, right? That is what is passing through. True. And it is passing through this upper triangle. So upper triangle, right? From here it is passing. This circumflex scapular, right? It would be going like this. Lower triangle, that's the best, right? Lower triangle. This lower triangle or the tricipital hiatus, triceps hiatus, radial nerve, and the profunda brachii, right? Radial nerve, we know that it is the continuation of that posterior cord, right? So it is continuation of that posterior cord. Profunda brachii, very important vessel, right? We see that. So here it is. Lower triangle, right? Here is the humerus. So this is 1. Teres major, that is 2, right? And long head of triceps, right? Long head of triceps, that is 3. And here is what we are getting is the radial nerve, right? We are getting this as the radial nerve, right? Radial nerve. It goes anterior to posterior, right? That's how it goes, anterior to posterior. That's the radial nerve. Now see, there are two more nerves which are going along with it. In fact, they are anteriorly, but just because they are coming into picture, that's why we are just watching it. This is ulnar nerve and the median nerve, right? Ulnar and median. So this one, right? This one is the ulnar and that's the median nerve, but they are anteriorly, right? This is we are watching it from the posterior aspect. And here it is our, say, profunda brachii, right? That's the profunda brachii. See, and from where it is coming out, right? Profunda brachii, it is coming out from where, right? See over here, right on the top. This is the area. This is the area. It is coming from there. What it is? This is, say, teres major, correct? This is teres major. And then that's like, say, humerus. And regarding this profunda brachii, it is branch of axillary artery, right? And it is this axillary artery, at what point we say that now the axillary artery, will call it a brachial artery. We'll call it a brachial artery. At what point we'll start telling it that now it is a brachial artery? That is teres major, right? That's the point. That's the junction, right? That is the lower border of teres major as it crosses. So anything before that, right? Before that is axillary, and after that it is brachial. So this is where we'll say that profunda brachii is branch of brachial artery, right? Brachial artery. Profunda means big, brachii means arm. So it is a big branch which is coming out of it, right? So that is what is called as the profunda brachii, which is branch of brachial artery, because brachial artery will call it as it crosses the lower margin of teres major. Perfect. From this point onwards, things are easy. This is axillary nerve, which is a branch of posterior cord, right? That's what we see. And this one will be continuing as the radial one, right? Over here, axillary nerve, that's the branch of posterior cord, and it follows posterior circumflex humeral artery. That's what it is going, right? This is good. And this anterior, this axillary nerve, it gives several branches. One is the anterior branch, right? This is the anterior branch. So that anterior branch, which goes along with posterior circumflex humeral artery, and it goes above and it supplies deltoid. Then there is a posterior branch, right? It supplies teres minor, right? Which is going over here, right? That's the posterior branch. And then there are some cutaneous nerves, right? So they supply that entire area. Okay. This is anastomosis around body of scapula. When you read the whole thing like this, it is so confusing, right? It never enters, at least it was never entering into my brain. So what I did is, see, let's draw it, right? And it's a fun. Draw along with me. Here is our main, right? This is what? This is our subclavian artery, right? This is our subclavian artery. From subclavian, there is a trunk which is emerging. This trunk is called as the thyrocervical trunk, right? This is thyrocervical trunk. So this thyrocervical trunk will give one branch, and that branch, right, is like this, and we'll call this branch as suprascapular artery. So that's one, first one. Then there is one more artery. Again, this would come from thyrocervical trunk only. So we'll just draw it like this, and we'll call it transverse cervical, right? This is, let me change the color. This is transverse cervical, correct? This one, right? This was our suprascapular. This is transverse cervical, and then another branch goes, right? This is deep branch. So how it is doing? Two branches, they are coming from thyrocervical trunk. So that is from the subclavian artery it is forming. So this is one area. And now as it crosses that first rib, so now we'll call this what? This is our axillary artery, right? This is our axillary artery. And in axillary artery, who is dividing the axillary artery into three parts? First part, second part, third part? Well, it was the muscle called pectoralis minor. Correct? It is the pectoralis minor. Pact minor. In pectoralis minor, in the third part, right? In the third part, there were three arteries coming up. One was anterior circumflex humeral, posterior circumflex humeral. Correct? These two, they were already there. Third one was subscapular. So it is this subscapular, right? Right? It is subscapular which is going. So subscapular. But then there is one artery. It is circumflex scapular artery. Now this is the artery what we were talking about, that which is passing through that upper triangular space. This is the third one, right? That's the third one. That's the third one. This is circumflex scapular artery, and that's how they do the anastomosis. So actually speaking, it is the third part of axillary artery and the subclavian, right? These are the areas which are getting anastomosed over here. So that's what you will say, that it is the axillary artery third part and the subclavian artery, that's what they are into anastomosis, right? So this is how you will draw, and when you will read this thing, this is exactly it is, right? And it would start making more sense. Okay, so let's see these. Suprascapular artery, right? We said suprascapular, which is emerging from thyrocervical trunk. Here it is. Let's zoom it, right? Here it is, the thyrocervical trunk. This one is thyrocervical trunk, and from there, here it goes. So that's our first candidate, right? That's our first, that is suprascapular artery, first one, right? Let's see the second one. Second one was what? There was a transverse cervical artery and its deep branch. Again, it is coming from, yes, it is coming from that only, right? Thyrocervical trunk. Here is the thyrocervical trunk, and this second one, deep cervical, and it's one branch, deep branch is coming, right? So that is the second candidate. And the third one was which was coming from the third part of axillary artery, right? So here it is, third part of axillary artery, and third part was giving this subscapular artery. Rest of the two were that, correct? These were the two other branches, but this is circumflex scapular artery. That's our third candidate which is coming over here, and thus they form the anastomosis between third part axillary artery and subclavian artery, right? And that's how they both anastomose. Good. Similarly, this is acromion process. Again, will not read this, right? Will form it, will make it. How will you make? Same style, right? Same style, and we'll just draw it like this, right? This is our subclavian artery, because now we can write it in short, and we'll always write axillary artery, and in axillary artery we'll draw it like this. So we know that this is our pectoralis minor, right? Now in this pectoralis minor, this is a communication between second and third and the subclavian, right? So let's see which arteries they are taking part. We'll draw the arteries with yellow because it is seen more clearly, right? And over here, so it is always like that thyrocervical trunk. So from thyrocervical trunk, can same one, right? Suprascapular, right? Suprascapular artery. And this suprascapular artery, it is giving one branch because it is going towards the acromion, so we'll call it acromial branch. We just write A because we know that we used to write ABCD, correct? So acromial, pectoral, clavicular, deltoid. So that's why we are taking a liberty just to write A. So that is the acromial branch of suprascapular artery, which is branch of thyrocervical. It is coming from subclavian. Okay, rest of the arteries, this is one. This is what? This one is posterior circumflex humeral artery, right? This posterior circumflex humeral artery is giving a branch, right? So that's our second candidate, right? Which is posterior circumflex humeral. That means it is coming from the third part. True. And then from the second part, it was thoracoacromial trunk, right? I'm just writing thoracoacromial trunk, right? And in thoracoacromial trunk, it has got four branches which we used to write like ABCD, but we wrote as at APCD. So this is A is acromial. You must have guessed. Yes, that's the branch which is going over there, and that's our third candidate. So here it is how the anastomosis is formed between second and third part of axillary artery and the subclavian artery, and that's the anastomosis, right? That's the thing what really happens. Let's see these arteries. So easy. See, all of them. Here it is, the first one, acromion suprascapular. See, here it is coming from the back. That's one, right? Then acromial thoracoacromial artery. Yeah, here it is, right? Thoracoacromial artery. Here it is. This one is, let me draw it with black. Here it is one, the second one, right? And then third one, that's the posterior circumflex humeral artery, and it is giving the branch which is going above. So this one is the third one. So that's the anastomosis just above the acromial process, right? So here is superior transverse scapular ligament, right? This is the ligament which we are talking about, this one, right? In scapula, it is like a notch, suprascapular notch, and it is converted into a foramen. All you have to remember is it is important because suprascapular artery and nerve, they pass through it. So artery is above, that's artery, and nerve is below, right? So it is like artery, right, is above, nerve is below. Army is above, navy is below, right? That's how we remember. And finally, this is the conoid ligament, right? That's the ligament, conoid ligament. And this conoid ligament, it is a cone-shaped ligament, cone-shaped. Its shape is cone-shaped. Whenever the cone shapes are there, it gives strength, right? It keeps the clavicle near the coracoid process, right? So that joint is not disrupted. It just gives strength. So that's it for today, right? This was the scapular region. Tomorrow we'll be talking about the osteology, that is all the bones. Go through this entire thing properly so that nothing is left by chance, because now once the scapular region is complete, tomorrow we'll be going into the depth of bones, right? And then we'll be proceeding for the arm, right? So thank you so much, and we meet soon. Bye bye. Yeah, we'll work on it. All right. Thank you.